All right, next we have Ann Weiss from the Robert Wood Johnson Foundation. Ann is a managing director there, and she leads, as you may know, the foundation's focused on building a culture of health. And Ann is focused on the health and healthcare delivery system transformations as a part of that. Before Robert Wood Johnson, Ann she has a long distinguished career in federal and state policy. She was at the New Jersey Health Department working as a senior assistant commissioner there and led the oversight of the payer and provider quality in the state, and also was responsible for the indigent, you know what I mean? Care programs there. And before that, she worked in DC for 10 years, both for the Senate Finance Committee and at OMB, the Office of Management and Budget. So Ann.
Hi, everybody. So like your program says, I was asked to talk about how innovation can draw on the field of behavioral economics. So this is this discipline that sits at the intersection between economics and psychology. And the question is how we can help the people who give care and the people who get care and the people who pay for care, how we can help them make better choices using insights from this behavioral economics field. And I don't want to use a lot of my time today to delve into the details of behavioral economics. So like many other speakers at this conference, I went right to that bastion of truth, Wikipedia, for this definition. And this is all you get. Behavioral economics studies the effects of psychological, social, cognitive, and emotional factors on the economic decisions of individuals and institutions, and the consequences for prices and returns and resource allocation. Now, I was here yesterday. This is my first time at this conference, and I learned the hard way that most of the speakers have great jokes. So I went back to my room last night and Googled behavioral economics jokes. And you're not going to believe this, but on the whole internet, there are no behavioral economics jokes. So that right there, that was your last laugh until I sit down. So I hope you enjoyed it. I also do want to say a word about the organization that I'm privileged to represent, the Robert Wood Johnson Foundation. How many people here have heard of the foundation? Great, that's wonderful. I can't see you in the overflow room, but a lot of people here. So we do have a vision. We're the largest foundation in the country focused solely on health and healthcare, and we have a vision for a culture of health, which really just means a society in which everyone has the opportunity to live the healthiest possible life, no matter what their background is or how much money they have or where they come from. Now, we know that only about 30% of health outcomes really are determined inside the walls of the healthcare system, right? So that building a culture of health, people often think about how important it is to pay attention to the social determinants of health. Do people have access to healthy food and places to exercise and safe, healthy places to live? But I think that building a culture of health also involves innovation in the healthcare system, and it's why I'm happy to be part of this panel today. Because in a culture of health, everybody should have access to affordable, quality care. No one's excluded. Healthcare should be efficient and equitable so that the economy is less burdened by wasteful and unwarranted spending. And I don't think anyone in this room thinks that this is the healthcare system we have today. So my job was to think about how behavioral economics could help us get there. And I'm going to do that by talking about 3 trends. You've already heard about all of them so far, and I think they're probably familiar to all of you. I'm going to give you some example from work that we and others have supported. But just as important, I'm going to be pointing out places where we're not using behavioral economics insights, but I think that they would help us. Just to give you a peek, here are the 3 trends: the broader adoption of payment models that reward value, continued evolution in benefit design, and changing expectations by and for patients and consumers, their families, and their caregivers. So let's jump right into that first trend. Medicare and private health plans are moving toward paying for care, not just on a fee for every service basis, but using these alternative payment models that reward better quality and lower cost and better patient experience. And we heard about this from both the previous speakers. The previous administration set a goal of sort of roughly tying 85% of Medicare payment to some notion of quality or value. By 2016, they hit that goal ahead of schedule. Implementation of the new MACRA law that will govern Medicare physician payment is continuing in the new administration. I think Imad and I might have different numbers when it comes to the pace of change. Major national health plans like Aetna and United and Anthem and others, according to the tracking scorecard of the Catalyst for Payment Reform, are moving past the 50% mark. And we definitely have a long way to go. There's still a lot of fee-for-service out there, but we are starting to see the change happen. Now, we could have a whole conference just on how the election might affect this trend, but I will save you time because I've been going to all of those conferences, and I can tell you that most people think that the trend toward these different PMO models will continue. What's important for us is what behavioral economics might have to tell us about whether and how all of these financial incentives are actually going to change behavior, in the healthcare system. Whatever way we pay doctors and hospitals, fee-for-service or something else, it obviously is going to motivate behavior, either in ways we intend or ways we don't intend. Fee-for-service certainly created an incentive for physicians to do more for their patients, especially more profitable things, and it often made it very hard for them to do the things that they thought would actually benefit their patients. So here's the important point. What behavioral economics tells us is that financial incentives are not the only thing that motivate behavior. There are very powerful intrinsic incentives that shape behavior, which is just a fancy way of saying that in many situations, for most of us, there are other motivations, things like professionalism or a desire for autonomy or mastery, that are as important as the promise of material reward. I think it's important. I'm not a clinician, so I feel a little silly saying this, but it's very powerful for me to really understand that the whole culture of medicine really is built around the concept of doing more. Physicians are trained in residency to be thorough. We've heard again and again from physicians that in parts of their training, they were almost taught that thinking about what the care would cost was almost sort of unethical in some situations. Behavioral economics also tells us that there are different kinds of cognitive biases that affect the way physicians make decisions. So for example, quite understandably, you tend to get too much weight put on the possibility that you will miss something or harm a patient by not doing something, and often give too little weight to the possibility that you might harm a patient by doing too much, like an unnecessary test. We've also learned that changing practice patterns is especially hard for physicians because if you show them data about their practice, you're basically asking them to confront the reality that they might not have been doing the best possible thing for their patients before. And that's pretty hard. Also important, changing incentives doesn't work if the people in the work environment don't know what you want them to do instead. And it doesn't work if the working environment makes the change impossible. They're very hard to adopt. So our grantees, as they've been testing this application of behavioral economics to healthcare innovation, what they've mostly focused on is making the healthcare work environment and culture more supportive of and sort of reinforcing of the financial incentives. Does that make sense? Yeah. It's very complicated to do this. It surprised me to learn, and it may surprise you, that underneath the design of all these very fancy alternative payment models, there's often a lot of business as usual going on. There's very little often that trickles down to the rest of the organization. Lots of people are still paid fee for service. Lots of people are still paid more for doing more. Frontline and mid-level workers who can make or break an innovation often don't even know that they're part of an innovation or a new way of doing things. So that limits how much the change is really going to affect the organizational culture. We've also learned a lot about bright spots, and one of the most important bright spots is that you only need to make relatively small changes in workflow in the clinical environment. You might need to make a lot of little tweaks, but you don't need to turn the whole place upside down to reinforce the financial incentive with culture change. So at the bottom of this slide, I summarized the three things that are coming out from our work in this area. Being careful about how you give physicians feedback, thinking about the role of a non-clinical workforce in implementing an innovation, and the power of small changes in workflow. Now, my slides are available to you, and there we go. You will see that throughout my slides, I've included some resources so that you can dig a little bit more into some of the materials some of the points that I'm making. So here's more for you to dig into. I want to call your attention to the work of the McCall Center on Healthcare Innovation. They've just released a bunch of materials to help physicians learn how to be peer leaders in emphasizing high-value care and eliminating low-value care. And also, I love the value-driven outcomes work of the University of Utah. And you may have seen this featured in the New York Times, but they have these teams of clinicians and administrators who focus on pain points and waste around the institution, and they do it in terms of, they address it as a part of their role as stewards of medical resources. So I want to go on now to the next trend, which is this evolution in benefit design. So what does insurance cover? How much is it going to pay? How much is the patient going to have to pay? Where can the service be delivered? For the purposes of behavioral economics, I want to stress the potential of VBID, value-based insurance design. This, of course, is where health insurers structure benefits to encourage members of a plan to use more of the services that we know can improve health and to use less of the services that we think won't improve health. VBID is where we hear about many of the things that we heard from Imad, like tiered networks, centers of excellence, reference pricing, high deductible plans. We don't need to get into all definitions. I think the question for us is how much VBID is sort of just a blunt effort to get people to use less care, and how much it's really designed to shape behavior by patients and providers. So I do think we have a little ways to go in this area. Yesterday, we talked a lot about high deductible health plans. Last year, 29% of Americans were in a formal high deductible health plan, but over half of Americans, of workers, were in plans that had a deductible for single coverage of more than $1,000. So these are people with an incentive, at least until they hit that deductible, to think about whether and when and how they want to get care. We know from the RAND health insurance study that when people are asked to pay more for care, they reduce their use of care across the board, whether it's high value, medically necessary care or unnecessary care. Everybody knows about this pitfall. And so the sponsors of high deductible health plans usually try to make available to their members some kind of decision support tools to help them use care wisely. But studies tell us that this doesn't work, because right now people in these plans have overall reduced their use of needed services, reduced medication adherence. They haven't reduced unnecessary trips to the hospital or the emergency department. And these impacts are worse for low-income workers. So I think here there's unrealized potential for behavioral economics to tell us more about how we can take these financial incentives and turn them into the behaviors that we actually want to see. Another thing to know is that VBID, which started with employer-based health plans, is now moving into Medicare this month. Medicare is beginning an experiment with value-based insurance design in Medicare Advantage, where people are going to be able to pay less and get more benefits if they have certain chronic conditions like diabetes or chronic lung disease or other conditions. I don't know a lot about the details about this, but I am hoping that this is an effort not only to change what people pay, but also gives them other kinds of supports to help manage their conditions. as Congress talks about repealing and replacing the Affordable Care Act, we're also hearing a lot of VBID concepts. And one you hear a lot about lately is what's going on in Indiana's Medicaid program. So in Indiana, they have these HIP power accounts where Medicaid enrollees are encouraged to act as prudent consumers and shop for care. This experiment has gotten a lot of attention because, of course, the administrator designate of CMS helped design this plan in Indiana, worked with them extensively, and because we know that Congress and the new administration are very interested in state experiments of this type. Now, the results of this experiment so far are mixed. There's some very good things about it and some things that are more concerning. And again, on the next slide, I've given you resources if you want to learn more about that. But the point here again is what can we learn from what we understand about human behavior so if we want Medicaid enrollees to make good choices, we have to do things besides how we pay for their care. We have to engage them in other ways. I wanted to emphasize a bright spot here, which is called engaged benefit design. So this is a health plan in Colorado. It's actually a collaboration of health plans and systems and a foundation. And they have designed this thing that pays patients to use a decision support tool and pays hospitals and doctors to engage in a shared decision-making conversation when the patient has the kind of condition where there are several acceptable clinical approaches depending on the patient's preference. So think about low back pain, think about early stage prostate cancer. The evidence from this design is that overall, these patients use care less. They undergo a much lower rate of procedures. Again, this isn't skimping on necessary care because there are a number of acceptable treatments. But why this incentive seems to work so well is that it's directed at the patient and the doctor, and their incentives are aligned. Again, some resources if you want to know more. The last trend that I'm going to talk about, and we've heard quite a bit already, is the growing importance of the role of patients, consumers, their family members, their caregivers. It's in many ways a natural consequence of what I've already talked about. People are being asked to pay more for care. They're being asked to make more decisions. But I think there are opportunities, further opportunities to really engage people in getting and staying healthy. What I wanted to do here is share the results of a study that we recently supported of the information needs of vulnerable consumers. So these are people from different racial and ethnic backgrounds, low-income patients and consumers. And what we learned from this study is that most vulnerable consumers feel disrespected by their providers and by the systems where they're cared for. And this clearly translates directly into non-adherence with treatment plans and regimens. It's pretty clear that making sure that patients and families feel respected by the systems where they're treated, regardless of their income or their coverage status or their background, would really go a long way in helping them stay healthier. Again, this reminds us of all the things that we care about besides money. Respect in this example. Convenience, we heard about the growing importance of the urgent care and minute clinic movement. The desire to live a healthy life. And I think a truly innovative, transformed healthcare system is one that's not only designed around the way that people deliver care and around clinical outcomes, but really meets the needs of the people that it serves. I really resonated with a lot of what the two previous presenters had to say about the change, sort of growing consumerism in our society, the growth of mobile technology, and just a very different attitude in general toward what people expect from a consumer experience. I do think I have two sons in their 20s, and I can definitely say that they are very different consumers from the kind of consumer I was in my 20s, and I think we can expect that to change to really affect healthcare innovation as well. I can't point to a specific application of behavioral economics here, but I can endorse the importance of, as you go about the business of healthcare innovation, of listening to the voices of the customer, the consumer, the patient, the community. There is evidence that when people feel in control of their care, care gets better and costs can be lower as well. So again, you have more resources here, and I'll sum up by saying, just summing up the three trends I talked about and what we can learn as we go about this business of innovation. The broader adoption of payment models that will reward good care is promising, but we have to acknowledge that financial incentives alone aren't enough, and you have to really think about implementation in the work environment and the culture. We are seeing evolution in benefit design toward a greater emphasis on value, but I think we don't really know yet a lot about how to use behavioral economics effectively. And I think as we see the expectations of and by patients and consumers, we should keep in mind all the things besides money that matter to people: respect and convenience and the need for information, and we should definitely remember to listen to the voice of the customer. Thank you very much.